We're especially privileged today to have a guest speaker from the Department of Surgery. I think he probably needs no introduction to this group. Bill Marston is well known to all of us as the Chief of Vascular Surgery in the Department of Surgery. He's also the medical director of the UNC Wound Healing Center, which is, I think, a center that we all use very often and have learned to respect. Bill's training background is stellar. He received his BA at Harvard, and then his medical school training was at the University of Virginia, Charlottesville. And following this, he did a general surgery residency here and a fellowship in vascular surgery here. He has a number of career interests that span vascular surgery, particularly wounds and how to heal wounds in the setting of chronic venous insufficiency, chronic arterial insufficiency. He's done work in endovascular surgery in both venous and arterial disease, and recently has done some collaborative work with, I think, peers at Duke on angiogenesis, and he'll probably talk some about that, and also some work, which he's going to discuss today, on wound care and the use of hyperbaric oxygen therapy. So, Bill, I'll turn it over to you. Great to have you.
Thank you so much. Well, I really appreciate the opportunity to come speak with you all. I think many of you have referred patients to us at the wound clinic, and those of you that don't know where it is, we invite you to come visit. We're on the second floor up where orthopedics used to be, and we're happy to have you come in either just for a quick visit or spend a day with us, either way. So initially the title of this talk was wound care and hyperbaric, but that's a pretty big topic, so I thought I'd focus it on the high-risk patients that we see. And this would be the complex diabetic foot ulcers, and obviously you see plenty of diabetic patients in your practices. And so these are the high-risk patients for limb loss, and I wanted to talk to you about how we manage them, what sort of standard therapy is, and then some of the advanced therapies we have to offer. We're going to talk a little bit about how we diagnose them versus other common leg and foot ulcers, then look at standard treatment protocols, and then some of the advanced modalities we have available in the clinic. And finally, I'll just give a few minutes on the utility of hyperbaric oxygen, which we started offering about 1.5 years ago here. We had a long history of working with the folks at Duke. They have a big multi-place chamber there. But it became clear that with these wound patients, it's much better to have them where you work with them on a day-to-day basis in hyperbaric. And I'll show you where it's useful. So if you look at all the wounds that we see, and we define a chronic wound as one that doesn't at least show signs of healing within about 30 days of standard therapy. And so the wounds we're seeing are these chronic wounds, and the common things are listed on the left side: arterial and venous insufficiency, various diabetic problems, chronic pressure, stasis edema, and really had this emergence of bacterial issues in the last 5 to 10 years. On the right-hand side are other rare diagnoses that we do see on occasion, but the left covers probably about 90 to 95% of the wounds that we see. So these are the diagnoses we look for initially, and then if the wound isn't progressing, we look for some of the rarer things. The thing we have to remember, just about every patient we see, there's a high chance we're going to have multiple etiologies. It's not just a pure diabetic foot ulcer from neuropathy. It may not just be a pure lesion due to arterial insufficiency. So you have to look for all these different factors in each patient to figure out what the way to go is going to be. Now, I'll apologize up front for showing smelly foot pictures while you're eating lunch, but this is the world I live in. I'm sorry. And there's no real purpose for this slide except that I like it. And this is America these days. And if we think about 40% of our patients are obese in our clinic. And obviously one of the key things, I'm not going to talk about it, but nutrition and weight loss would really heal a lot of these wounds probably by itself. We think that for most patients, we can get the diagnoses that they have by a good history. And I'm not going to preach to you on this. You should be preaching to us surgical folks about how to do good histories and physicals, but you really can tell whether they have arterial insufficiency by looking for claudication or rest pain. Have they had previous deep vein clots? Have they had previous vein surgery? Is there a history of thromboembolism? What about, obviously, their history of neuropathy? And then other things like lupus, scleroderma, those are really important to know about in these wound patients. Now, you can almost also, probably 95% of the time with that history and then looking at the wound. A wound that looks like this, that's a venous ulcer until proven otherwise. You have edema, you have a characteristic staining of the tissue, and it's in a location that you really don't see many other kinds of wounds. This is not a location you're generally going to get pressure, unless the patient has some strange motorcycle boot he likes to wear. Could be a burn on a muffler, but it's not a diabetic wound. They're almost always on pressure points on the foot. These wounds, these venous ulcers, drain heavily, and usually if you get rid of the edema and the drainage, they'll heal. Clearly contrasts with your typical neuropathic diabetic ulcer on the plantar aspect of the foot under a bony prominence. This happens to be a Charcot foot where the midfoot's collapsed, and you can see the prominent area here where it shouldn't be. They usually have a lot of callus around the wound, and they're typically, when they show up in the ER, infected. And then finally, an arterial ulcer usually happens on the toes, distal parts of the feet, and there tend to be punched out lesions, very painful. They don't have edema, and they're pulseless. So you can generally separate these out if they're pure wounds, and then you can look for the individual factors in patients to get these diagnoses correct. So from here on, I'm going to really focus on the diabetic foot ulcer. And the real reason to do this is that of all these chronic wounds, they're responsible for limb loss more than any others. It's a major predictor of limb loss and clearly acceleration of mortality. If you look at the annual incidence, somewhere around 5% of all diabetic patients will get a foot ulcer yearly, and the prevalence is in the same range. The lifetime incidence for a diabetic patient is about 15%. The key thing is that about 85% of the major amputations, that's a below or above knee amputation, is preceded by a non-healing foot ulcer. So we did a study a few years back, and we looked at all of the patients that went on to get a major amputation. What of these risk factors did they have? And about half of them had both diabetes and arterial insufficiency. About 30% were non-diabetics that had significant arterial insufficiency. And the majority of the rest were just pure diabetic patients that didn't have arterial problems but had recurrent infection. They come in and lose a toe to an infection, then lose another one. A year later, lose a metatarsal, and pretty soon they have to have an amputation. And that's about all the ones we had. We did another project where we looked statewide, and we looked and we said, you know, what's going on in our state with limb loss due to diabetes? And you can see we tracked it from 1990 to 2002, and there was a huge rise between 90 and 99 of about 77%. And these are the raw numbers. And then we've started to see a little trailing off, and that's continued to happen over the last few years. Sorry about that. We'll get it back where we need to be. There we go. And up to 2005 now, we're down about 10% over the last 5 years. If you look at the rate, because our population's been rising, the decrease has been a little more significant, about 15% over the last 5 years. I wish I could tell you what the causes of this decrease in the incidence of amputation would be, but we don't have the data statewide to be able to tell you. We hope it's that almost all the hospitals now throughout the state have defined wound programs. So as opposed to 1990, when I first started working here, you didn't know where to send a patient in a place like Lumberton with a foot problem. There was the primary care, there were general surgeons, it was sort of a hodgepodge, and you didn't know who to send these patients to. But now with almost every hospital having a wound program, we know where to send them, and they should have certain expertise in managing these problems. So this is a county-by-county incidence of amputation in diabetic patients. And so basically the blue counties are good, the tan are about average, and the orange and the red are really bad. And it's no surprise that it tends to be rural counties, particularly in the eastern part of the state, with the exception of the Cherokee Tribe County out west, which unfortunately has the highest rate in the state. Now, some of the factors we found by looking at these counties, if there's a higher incidence of population below the poverty line, lower median income, increased minority population, lower population density, and fewer physicians per capita, we saw higher rates of limb loss. Now, what is it that causes diabetic patients to have wounds and then go on to lose limbs? Well, almost all of them have neuropathy. And, any of us, hopefully, that don't have neuropathy, if you get a small blister or a little wound on your foot, hurts you so much you can't walk on it. You auto-offload that wound. Well, these people can't feel. They can, stick a nail in their foot. I mean, we do all kinds of surgery on these patients without anesthetic because they have dense neuropathy. That is the critical problem. And also, it's an abnormal mechanical environment with some bony abnormalities that I'll show you in a minute. Many patients have these complicating factors, and it's the ones with vascular disease that run the highest risk of limb loss. And also, they're at high risk for infection. So this is the most common test. Now, you don't have to have one of these fancy multi-filament devices. A single 5-0 monofilament test is very adequate to define neuropathy. And so if you're seeing your patients and they do have, they fail this test, they just need to get in for screening, and we'd be happy to see them at the clinic. Our podiatrist, Dr. Koszewski, does a great job in offloading these patients, making sure their footwear is good. The orthotic group here also does a great job. But that's the thing to do to try and prevent ulcers, and clearly education so that they understand the problem and will participate in its treatment is critical. Now, this is the mechanical environment I talked about. You see these hammer toes or claw toes that patients develop. And if you look on the drawing here, there's a fat pad that is supposed to sit right under the head of the metatarsal bones. When the neuropathy causes the muscles to draw dorsally, that fat pad migrates away, and it moves out from under the metatarsal head, and now you've just got skin and bone. And that's a terrible environment for ulceration when you put it together with neuropathy. And that's why they tend to get these right on the metatarsal heads. Also, the tips of the toes are curled down, and they're not meant for that type of pressure. So that's generally where we see the wounds. Or sometimes right on the dorsum if the toe box in the shoe is too tight. One of the best things you can do, simple thing in these patients, you see this kind of claw toe, you got to get them out of their stylish, narrow shoes into something with enough room that's going to accommodate this process. Right there, that's going to prevent quite a few ulcers. The other thing we find that happens very frequently is the Achilles tendon becomes tight. They can no longer dorsiflex the foot fully, and that puts more weight on the forefoot, again, increasing the risk of ulceration. So you can loosen that up in some of these patients with physical therapy, and if that's not successful, there's a percutaneous procedure to release that tendon part way to take that pressure off the forefoot. So these are things we look for in the clinic, particularly a patient that's had an ulcer. They should have these procedures done to correct this environment. You can straighten the hammer toes in more severe cases to unweight them. A lot of things like that can be done for these patients so they don't get wound after wound over years of time and limb loss. Not going to go into this in detail. I think you all are aware that folks with, severe diabetes, poorly controlled diabetes are very susceptible to infection. We clearly see it in these patients. Some of them is really virulent and they just get recurrent infections that end up causing limb loss. The vascular disease in diabetic patients is atypical. In non-diabetic patients, we tend to get disease in the aorta, the iliac arteries, maybe the femoral arteries. But in folks with diabetes, those vessels are usually preserved. And where we see it is down below the knee in the small tibial arteries. And it used to be that we really couldn't correct this problem in most patients up until about the mid-90s. Since then, there have been several techniques developed to manage these distal diseases with endovascular methods. We'll talk briefly about that later. So what is the natural history of a patient with diabetes with arterial insufficiency? What if you don't correct their blood supply? What's going to happen? We published a paper in 2006, and there are a certain number of these patients that, for numerous reasons, you can't revascularize them. Either they have severe comorbidities, anatomic limitations, or the patient just refuses. And we got about 169 of these legs over about 5 years' time that we couldn't revascularize. and we wanted to see what happened. So we treated them with the best techniques we had, and this was the outcome. At a year, about a quarter of them lost the leg. And obviously that's not good. That's a pretty high rate of amputation, but we were kind of worried it was worse. We generally think that we got to resupply the blood to these limbs if we're going to have a chance of limb salvage. But the fact of the matter is, most of the time with good care you can keep the limb on, although unfortunately the rate of wound closure was not very good. It was only about 50%. So you heal about a half of them with a year of good hard work in the clinic. About a quarter of them still have the wound, but they also still got the leg. Hopefully they're using it. But about a quarter of them go on to limb loss. So clearly, if we can revascularize the patients, that's better. So in summary, they have sort of this perfect storm of an insensate foot with mechanical abnormalities. So they get excessive pressure that causes a wound like this one here under the 4th and 5th metatarsals. This patient has a little bit of exposed bone, probably has osteomyelitis, and walks into the clinic, in their tennis shoe. They have poor circulation, possible immune dysfunction, and that's what gets them in this place. So how do we treat them? What do we do with these folks when they come in? First thing, obviously, we're vascular folks. We check the blood supply. That's the number one thing. We generally feel if we got good blood supply, we can generally heal the wound. We debride off any non-viable tissue. It tends to harbor bacteria, and it increases the pressure on that area. And then the second most important thing after blood supply is pressure relief. And so this involves a variety of techniques, but anything you can do to get the pressure off. You can use casting, you can use crutches, you can use orthotics, whatever it takes. And the bottom line is you got to work with the patient. Most of our patients really aren't very stable on crutches, so I tend to stay away from those because I hate to heal the wound and have them fracture their shoulder because they fell over, and then you've got a whole other set of problems. Infection, bioburden control are critical. We'll talk about that in a minute. And there's about 5,000 products you can put on a wound, but we generally keep it simple. We keep the wound moist. We don't want it to dry out. We don't want it to be too wet, and we use products that will do that. So the great revolution, I guess, in vascular surgery has been the move to less invasive therapies, and this is using balloon and stent technology. And we have been able to finally get adaptation of a number of the coronary techniques with small guide wires, small stents to use in the tibial arteries to reopen many of these vessels. So at this point, we can use a minimally invasive approach to reopen arteries in about 50% of diabetic patients. About a quarter go on to needing standard bypass surgery. And, bypass surgery still works well. It's sort of a dinosaur, but for selected patients, it really does a good job of resupplying blood. And the nice thing about it is once you do it, it tends to last a long time. A 5-year patency with these grafts is usually about 70%, so it's a pretty good long-term result. The problem is there's about a quarter of the patients that none of these techniques work to really fully revascularize the leg. So we're still seeing what we can do to manage them in the wound clinic. Debridement is a straightforward technique, and these are pictures of all kinds of things you got to debride off the wound. This is what we call slough here. It's fibrinous material, clings to the wound, and it harbors biofilm bacteria. It needs to come off. This is eschar. That should come off too. And you just do these with a pair of forceps and either a curette or a scalpel. And it's just superficial. You're not going deep. It can be done in the clinic. And we'd be happy to show any of you all how to do this in the clinic if you want to learn. This is a pretty typical appearance too. A lot of callus around the wound that needs to come off down to healthy skin. And this is a typical patient that comes in and they say, well, I'm all healed, Doc, and you look and there's this callus over what appeared to be a bigger wound that's now closed down. The problem is that it's really not healed. After you debride it, there's still a wound under there. If you don't get this stuff off, it tends to trap drainage underneath that callus and can get infected. So in these patients, callus has to come off. It's not a normal acute wound that's going to heal and scab over and epithelialize. They won't heal with this callus on top. Now, the gold standard for offloading to get the pressure off the foot is a total contact cast. And Dr. Krzyzewski does these in the clinic, and it really works well for forefoot ulcers on the metatarsal heads and toe ulcers. It's labor intensive, and the patient has to be very compliant. We do this, they come back weekly for changes so we can examine the wound, make sure it's not getting infected. Patient has to be able to tell you, something doesn't feel right if it's, in the middle of that week and come back, because if they don't come back, the foot can get worse if they ignore an infection. So this is something we do probably in about 20% of the patients. We don't find it's applicable to a fair number of our population. And this is well recognized around the country. In fact, it's, we probably do it about as high a rate as anyone in the country. So other strategies include this. This is the removable diabetic walker, and it's designed to basically do what a total contact cast does, except the patient can take it off at night. They can change the dressing daily, they can wash it, they can look at it, and it should provide the best of both worlds. The problem is it doesn't. The reason is because it's removable. And when patients remove it, who's going to put it back on? It's up to the patient. So this was a really ingenious study that David Armstrong did at University of Chicago with a few other centers. And what they did is they had patients enroll into a study, and they wore a pedometer. And they wanted to check walking patterns, and these patients had plantar ulcers, and they put them in these removable cast walkers. Well, unbeknownst to the patients, there was also a pedometer in the cast walker. And what they found was that they only wore the walker for, on average, 28% of their steps. So what Dave's group has done now is they use these removable cast walkers, and they put a bunch of Coban or plaster around it to make it into a contact cast. So what you really have to gauge is if your patients are going to be compliant, because if they will use this correctly, it works pretty well. And I would say we do this type of device in about 50% of our patients. The problem is it's a fairly thick heel, and the patients are a little bit unstable, and so there's occasional patients that we worry about falls, so we'll use a less bulky device. Now, to talk about bacteria, I would say up until about 2000, I hardly ever cultured a wound. I mean, it was rare that we had, if they're infected, you look at them and you treat them for infection, they get better, and then they do well. They hardly ever would get reinfected, once you were treating them. But with the emergence of some of the resistant infections, particularly MRSA and Pseudomonas, we're finding a much higher incidence of biofilm infections. And what these are is there's this continuum between just normal bacteria levels in a wound or on the skin and gross infection. And they tend to form these sheets of biofilm that look like that slough I showed you. And if you actually culture them out, do quantitative cultures, they're 10 to the 5th, 10 to the 6th bacteria. And it's become our impression that if you don't treat that, they just won't heal. They don't get infected. They're living in symbiosis. And most of the patients don't like it that way. So the infections are usually polymicrobial, but we're seeing much more of a dominance of resistant staph and Pseudomonas. If you really think it's a gross infection, we're admitting the patients just like you would and start with a broad spectrum and narrow based on our cultures. We don't really see a big use for topical antibiotics in general. I think there's one good use for some of the silver dressings. They actually probably prevent bacteria entrance to the wound through the dressing, but that's about it. They're not good for treatment modalities. One good piece of news, we're finding that almost all of the staph that is resistant to meth and oxacillin is sensitive to things like sulfa. So we use a lot of sulfa drugs, doxycycline. That really does a good job of taking care of it with a couple of weeks of therapy. The problem is when you stop it, these biofilms tend to recur, so you have to really keep on top of them. Now, this is my favorite wound treatment here, Boudreaux's butt paste. And if you go to wound meetings, they usually have a big booth and they give out a lot of samples. And I take it home and give it to my friends with young babies, and they're very happy. They like that. We don't put it on wounds, but I guess you probably could. There's so many things out there that what we look at is keeping a moist wound environment. Most of the diabetic wounds, if they're not infected, are dry. So you want to use a hydrogel, which is just the hydrated or gel form of saline. And the reason you don't want to use a wet to dry dressing is you have to change it 3 times a day to be effective, and the cost of the gauze is way higher than the cost of a hydrogel. So we have the patients do once daily hydrogel dressing changes. Unless you think it's infected or it's draining more, then we use an absorbent dressing like an alginate. So we try and keep it pretty simple. And so the question is, what are the results with this standard care for diabetic foot ulcers? And if you look at a meta-analysis that was done by David Margolis, and he looked at 10 clinical trials and their placebo treatment groups. And with these treatment protocols that I've just gone through, about a quarter of their patients were healed at 12 weeks, and about 30% at 20 weeks. Now, of course, clinical trials are a little bit skewed because they tend to exclude the easy healers in the run-in phase. But most protocols are not a whole lot better than that. And our own data, we heal about 50% at 12 weeks in our clinic. So, eventually we heal about 80% in 20 weeks. So, we can get most of them healed, but it clearly could be faster. When you talk to a patient, you say, well, we're going to put you in this cast, we're going to have you come to the clinic every week, and you might be healed in 3 months. They look at you like, well, that can't be right. In this day and age, you got to have a better treatment. So what is out there? So that's where we get to active methods of healing. And there really was nothing other than these what we call passive treatments until the late 90s. And the things that have come out since then have been growth factor therapies. The one that's available is platelet-derived growth factor. And then there are 2 living dermal substitutes, APLIGRAF and Dermagraft. And I'll talk briefly about these. So there's been a long history of clinical trials in diabetic foot ulcers. When they first began to be able to produce these growth factors, we thought that this would cure the problem and they'd all heal up. So this is a list of all the growth factors that have been in clinical trials. The top 1, 2, 3, 4, 5 all failed. There are no benefits to treatment with these. But PDGF did have a benefit. And this is available as Regranix. It comes in a 15-gram tube that unfortunately costs about $500. So it's wickedly expensive. And most of our patients, if they don't have coverage, will not be able to afford it. The data, there were 4 randomized trials, and if you do a meta-analysis of those 4 trials, what you find is that at 20 weeks of treatment, placebo was 37% and the Regranix group was 50%. That was a significant difference. So there is a benefit, but I wouldn't say it's a panacea. I mean, we treat patients occasionally with this, but we really look for better things, particularly because of the cost issues. So subsequent to this, in the late 90s, 2 different companies produced living skin equivalent products. And these are APLIGRAF and Dermagraft. There were several others that have been worked on, and actually Protodome will probably be the first 2nd generation skin product in the next year or 2, hopefully. The idea here is that the cells in these wounds are sort of burned out. They're senescent. If you look at the fibroblasts, they display poor proliferative capacity. They don't secrete chemotactic factors very well. They don't migrate. And the concept then is to apply some fresh, healthy living cells to stimulate wound healing. And both of these have a neonatal source. So human dermal fibroblasts were isolated from newborn foreskin after circumcision. Both APLIGRAF and Dermagraft use this as a source, and they can expand these in cell culture, so very few source pieces are needed. I think they take 2 or 3 per year is all they need to produce the cells they need. So APLIGRAF we'll talk about first, and this is a bilayer, which basically means it is designed to mimic human skin. It has a dermal layer and an epidermal layer with a stratum corneum. The only thing it doesn't have is hair follicles or sweat glands. And it was hoped this would work like a skin graft, basically. It basically puts out all the same cytokines and growth factors as normal skin does. And you can see it includes multiple growth factors, interleukins, TGF-beta, vascular endothelial growth factor, pretty powerful stuff. And it's very simple to do. We do it in the clinic. You don't have to take the patient to surgery. We just do a topical anesthetic and apply it after a good debridement, secure it with steri strips, and do a secondary dressing. Very straightforward. So in diabetic foot ulcers, they randomized 208 patients at 24 centers, and all these patients received the standard methods we mentioned and a good offloading boot. Their control population had 38% to heal at 12 weeks and 56% that were added to APLIGRAF. Significant difference, and that seems to be a pretty good benefit. So I would say we use that in a good 20 to 30% of our patients once they're cleaned up and really offloaded well. Dermagraft is the other living skin equivalent. It's a slightly different concept. As I said, APLIGRAF was designed to hopefully mimic a skin graft. Well, it doesn't do that. You don't put this on there and you come back a week later and boy, it's close. It really works more like a growth factor engine. You're putting in a bunch of protein and things to stimulate the wound. So these guys said, well, why do we need the structure? Why do we need to put all the time and money into making it look like skin if we're just putting in something that's going to spend a couple of days of giving growth factors to the wound? So what they did is they grow dermal fibroblasts. There's no epithelial cells here, just fibroblasts, and they seed them onto a vicryl mesh. So vicryl is, as you know, it's absorbable suture material. The mesh absorbs in a couple of days and leaves the cells behind. After a couple of weeks, you get a sort of a confluent layer of these cells, and then they kind of die off after they hopefully have stimulated the wound. And similar to APLIGRAF, you can look at multiple growth factors produced. They did some ear wound models, which is sort of the most sophisticated diabetic foot model for healing, and they showed a lot of angiogenesis into the wounds compared to controls. Their pivotal trial was done 314 patients at 35 centers, and pretty typical criteria: full thickness wounds, excluded osteo or infection, reasonably good arterial supply. And basically the results here at 12 weeks were 18% healed in the control group and 30% in the Dermagraft group. Now the numbers are different here because they didn't use a full offloading boot. They said, well, real world, these patients walk. So they put them into a custom diabetic shoe. And so one of the things you really can see from this is a custom diabetic shoe isn't good for these patients because it sort of gives them the idea they can walk. And if they're walking around, you see control 18% healed, that's not very good. But the Dermagraft group was significantly better. There's been some case series done since then using this with good offloading, and they're in the 60 to 70% healing range. So I think that with good offloading, you can probably get similar results with Dermagraft and APLIGRAF. This is designed to be done weekly for up to 6 weeks, and we also use this in a pretty good number of patients. You can see here in that study, the patients reported they were ambulatory for an average of 8 hours a day, so they sure weren't sitting around with their foot up. So to summarize the active products we have, they all provide a benefit. It's not enormous, but it's enough that we use these and we use them routinely, and we think it helps us heal more wounds. Now, what about the role of hyperbaric oxygen? And as I said, for many years we worked with Duke. We would send patients over there. We would see probably 10 to 20 patients a year that we thought would benefit from this. Most of these were patients with arterial insufficiency that we could not revascularize. But subsequently, there's been some data in more routine diabetic ulcers that suggest this may help. And there's a bunch of odd indications for hyperbaric, like osteoradionecrosis and various other ischemic conditions that a center like this can support a couple of chambers. The basic concept is that, if we take a patient and their lungs function reasonably well, we can put you on 100% oxygen and not increase very much the amount of oxygen in your blood, only about 3%. But you can dissolve oxygen in plasma at a much higher rate if you increase the pressure from 1 atmosphere to 2.5. You can increase from a PO2 of 600 to about 1800, so triple the amount of oxygen dissolved in the blood. And that is the real concept of hyperbaric oxygen. So the question is, where is it useful to have this extra oxygen dissolved in the blood? And basically, if you look at a wound, this is the normal situation. Okay, you've got a wound, and the center of the wound, some portion of that is relatively hypoxic. If you stick an oxygen probe in the center, you'll measure a PO2 usually of about 25 to 30. We're currently doing a phase 1 clinical trial with a company that has an oxygen device that is sort of hopefully a way to get away from needing to do hyperbaric. But they're measuring these oxygen levels in the center of wounds, and they're about 25 to 30 for a PO2. Whereas around the periphery, you should be 60, 70, 80 at least. So there's this difference between the periphery and the center of the wound. And the gradient, oxygen goes by a gradient. So if you've got a normal situation, there's going to be good diffusion into the center of that wound. However, in the hypoxic wound, the periphery is somewhat hypoxic as well. So if you measure the PO2 at the periphery of the wound and it's 40, there's not much of a gradient to lose oxygen. That's where we see a benefit in wounds. And so we measure these transcutaneous peri-wound levels in many of our patients to see whether they would benefit from hyperbaric. And so if you look at a capillary here and the amount of distance that oxygen will diffuse, it depends on the gradient. And so if you go from a PO2 of 100 to 2,000, obviously you're going to get a much wider diffusion of that oxygen. So that's the way we hope to oxygenate these hypoxic wound centers by doing hyperbaric treatment. There's been a large body of in vitro work that shows how tissue oxygenation can help by collagen synthesis, increase bacterial killing by leukocytes, and more rapid epithelialization. If you look at angiogenesis, as the PO2 increases in these wounds, you get an upregulation in angiogenic factors. And there's also been some interesting work on stem and progenitor cells where hyperbaric oxygen mobilizes these cells from the bone marrow. It seems to be a nitric oxide dependent mechanism, and the population of CD34 cells is doubled after a single hyperbaric treatment. So we really think that over a course of treatments there may be a real benefit to this. We're doing some other stem cell work that I'll show you at the end, but we think this may be a collaborative thing between hyperbaric and some of the other strategies. So what information is out there on hyperbaric oxygen? What do the trials show? There's been about 6 randomized controlled trials so far. And if I list these, the first thing that the astute observers there will do is look at the number. And these are not the things that dreams are made of. So I pretty much toss out these last 3 studies, although they were positive findings. The most important of these is a study from Faglia. Now, these are basically endpoints of limb loss. So you're not going to see 1,000 patient sizes when you're looking at limb loss. But the interesting thing here is they studied, this was a nice study done with sham treatment. So they had patients in a chamber without getting hyperbaric oxygen and those that did get it. And they studied their results. And what they did is they optimized their metabolic control. There were patients that had low ankle brachial indexes, so they were ischemic, and they had diabetic wounds. They had a treatment protocol of 2.5 atmospheres, which is what we do, and again, sham treatment sessions. Their results in the HBO group, only 8%, 3 of the 35, required a major amputation versus a third of the control group. So that was significant. They were planning to do more patients, but they actually stopped the study at that point with that finding. So I think that's a pretty significant study. It's a pretty good quality, though small, study. The other ones are even smaller, so there's certainly a need for more information, but we think that there's a benefit based on this. The other interesting thing was that if you measured the TCPO2 on the dorsum of the foot, the hyperbaric treated subjects had a significant increase. So there was a hemodynamic measure that showed the benefit as well. So just the final thing on this, this is a patient I treated back, this was actually in 2000, but this was the first case that made me think there was something to this. This is a young guy, he's about 45, and came in, obviously had a toe that was amputated and then it wasn't healing. And he was just, very compliant, great patient, but he had terrible vascular disease that was in the distal leg and the ankle, and we couldn't revascularize him. So we treated him for about a month or 2, and you can see we were getting nowhere. There's nothing going on here. So at this time, I was working with folks at Duke, and we referred him over there, and he came back about 3 months later, and obviously that wound is now healing. And when you have a wound that looks well granulated like this, it's going to heal as long as it doesn't get infected. So Hyperbaric did that for this patient, and he went on to heal, and he comes back every now and then to visit us, but he was a save. And so there's some dramatic cases like that you can do with a combination of standard care and hyperbaric treatment. So the last thing I have for you is just what's out there on the horizon. There's really quite a lot of interesting research going on in diabetes and diabetic foot problems. The most interesting things right now that are in clinical trials have to do with one that is a gene therapy for platelet-derived growth factor. And we're doing a phase 2 study right now with PDGF and gene therapy. It's topically applied, and we're about 3/4 through, so we're very hopeful for that. And then the other thing is the use of stem progenitor cells, and there are various competing methods of getting these cells that people are looking at from the adipose tissue, from the peripheral blood using apheresis, or direct harvest from the bone marrow. And the basic strategies are either to take bone marrow and expand these cells out, because you get a relatively low volume, takes a couple weeks to expand them out, and then re-inject them back into the leg to help develop collateral pathways for blood supply to resupply the limb. The other is to give patients Neupogen, mobilize the cells, place them on apheresis for about 4 to 6 hours, collect CD34 cells, and re-inject them back in the limb. And we are currently enrolling patients in both of these strategies with critical limb ischemia. Long ways off. These first phase studies will probably be another year to finish, but hopefully if they're actually doing what we hope they will, we'll have other alternatives rather than surgery and putting little metallic cages in vessels in the future. This is the design of that, the study with the apheresis. This is sponsored by Baxter out of Northwestern. And again, we've probably got about 1/3 of the patients enrolled so far. So in summary, I think that of the wounds we see, the diabetic foot ulcers are the most complex and the most risky ones, particularly when they're involved with arterial insufficiency. Although we see a lot of leg swelling and venous-type leg ulcers, and there are some equally interesting treatments for them, they just don't have the risk of the diabetic ulcers if they're managed well. And clearly, some of these novel strategies we hope will allow us to heal patients quicker so they don't have to go through 6 months of these terrible boots and come into the clinic every week to see us. So I'll stop there. I'd be happy to answer any questions. And again, we're happy for you to come visit us and see who we are. Thanks. That's a great question, and the question is, how do we think hyperbaric helps in the ischemic wound? And I don't think I can give you the mechanism, but I can tell you that what we do know is if you take the patients and you put them in the chamber and you measure that PO2 in the periwound area, if it doesn't go up over 300 or 400, then they get no benefit. If it does go up, most of the time you'll start to see some improvement. And I think that the issue is that it's not a black and white. They have arterial insufficiency or not. Most of them are somewhere in between. And it's just improving that supply marginally that will get them to where they can heal. The ones that are really severe, if you measure a baseline PO2 of 10 or less, they're not going to be helped. They're too far gone. And so if you can't revascularize them with surgery or something, they're going to lose their leg. Question? Yeah, that's a great question too. Combination of HBO and growth factors. And I will say that probably the biggest deficit in this whole field is the lack of any studies on combination therapies. Almost all the studies here have been done by sponsors getting FDA approval, the good ones. And there's not anything that as this field matures, that's where they need to go, is to looking at combination therapy, because there's a lot of people that say, boy, yeah, it would be a great thing to do is to hyperbaric and then put an APLIGRAF on or do some growth factor therapy. But we're doing it blind. We really don't know. Any other questions?
These angiogenic therapies that you're talking about, what's the usual time course you expect to see a change?
Yes, so we really look at the patients to select them for an angiogenic therapy based on how long we think they can go. So I would expect if you're going to, usually takes you a couple of weeks to get them harvested and get the cells ready to put back in. If you've got a patient that, has terrible pain and they're not going to be able to last a couple of months, they're not appropriate for that therapy. So we kind of look at these things as the worst patients would still need to go for revascularization. Those that have a few months, if these things work out, may be good candidates for that type of therapy. Rest pain, if it's not too bad, you can manage them for a while with some, lower level narcotic. That's probably a way to go. But yeah, we're seeing that, we've probably done a dozen patients, and I'm blinded, so I don't know. But the ones that do seem to benefit, it takes a good 6 to 8 weeks.
Any other questions? Well, thank you.
You're welcome. You bet.